Hello, I'm Kathy Chester, and this is Move It or Lose It, a podcast about all things that move the mind, body, spirit, and soul.
Well, hello. Welcome to another episode of Move It or Lose It, our podcast. Today, I am so excited about our guest. Her name is Meghan Beier, and she's a psychologist, and that's all I can say. Meghan, I'm so happy to have you. I had a cognitive flight moment when I read your bio and tried to understand what it is that your entire title. So go for it. You go.
Yeah, there's way too many pieces of my title, but essentially I'm a psychologist that specializes in working with people that have health conditions. So there's kind of three different styles of psychologists that I am, which is a health psychologist, which means I got training in working with people that have medical conditions. A neuropsychologist, so I got even more specialized training in neurologic populations like MS, like brain injury, like stroke, those kinds of things that impact the brain and spinal cord. And a rehab psychologist and rehabilitation psychology is working with people that have disabilities. So,
Okay.
so
Meghan, I'm
it's
going to
a
have you
little bit that.
go ahead and take those out. Yeah, because I think I can hear you better.
Okay.
Ooh, now I can't hear you.
Yeah, okay.
Better. Yeah, perfect.
Yeah, do you want me to repeat that?
Yes, if you can, that'd be great.
Okay, sure, no problem. Yeah, so I am a clinical psychologist that specializes in working with health populations. That's kind of global. But I have sort of three specialties or three areas that I've worked in. One is health psychology. So that is the psychology of working with people that have medical conditions. I then got even more specialized training in neuropsychology, which means working with neurologic populations. So any kind of medical condition that
Like our stuff.
spinal cord, exactly, like MS, brain injury, stroke, all those kinds of things. And then the final part is rehabilitation psychology, which is working with people that have disabilities or have chronic lifelong conditions. So I'm a little bit of all three of those wrapped in one.
How common is rehabilitation psychology? I don't believe I know very much about that, or have even heard much about that.
Yeah, it's pretty small. So
Okay.
the umbrella is health psychology. Neuropsychology is sort of its own animal. There's
Mhm.
thousands, I would say several thousand neuropsychologists in the country.
Not enough.
Not enough, but yeah, I mean, it's still hard to find people. And I would say when I go to my annual rehab psychology
Mhm.
conference, which is coming up next week, there's about 300 people. There's probably more,
Wow.
but it's a pretty small field. I think a lot of times when people hear rehab, they think drug abuse.
Right,
And so,
true.
yeah, and so it's not as common, but if you go to any major rehab hospital, you're probably
Or
going to.
not psychology. You think, rehabilitation from an injury or car accident or something like that,
Yeah,
but not psychology.
right. It's much more common. Rehabilitation psychology is much more common for brain injury
Mhm.
and things like that. There's just been more funding and more research there. And so I think there's more psychologists that have gone there, but MS needs it just as much.
Right. So going from there, you started there. So now tell me what got you into this. Like what brought you into going into caring about MS? Because there's no one in your family, right? No one that you know that has MS. What got you into the neuro area? What was the passion that drove you?
Yeah, so when I was always interested in psychology. Um,
Mhm.
I was in an undergraduate class called Biologic Basis of Behavior, and there was a like 1 paragraph thing about neuropsychology, and I was like, oh, this sounds really cool. This would be a really cool career. But then I realized I had to go to like 7 years of school to do that, and that was like not
Right.
top of my priority list. So I took a break after college, and I worked as a research assistant for a while, and then I worked as a direct care worker, which meant that, I took people to their doctor's appointments, but it was with people that had brain injuries. So I would take
Okay.
doctor's appointments. I would make sure that they had food and take them grocery shopping, and I just loved it. I loved
Yeah.
working with people. I felt like, there was something about really seeing people for who they were and not for their
Mhm.
diagnosis. And
Yes.
I remember even back then, even before I went to grad school, telling people, you know, um, this person is not their injury, right? Like they're telling
Right.
all the stories about their history and their past, and just because they don't have the same life that they did before doesn't mean they're less valuable. And I
Just
really,
that, Megan, you're going to make a lot of people cry who are listening to this because we've
yeah,
had so much of that. We go, so you're going to make me cry. I can't cry in the podcast, but you go so many times where you feel invisible and you feel like nobody's hearing you or listening. And so to have someone with a compassion like you have, to want to be in a class and say, or in a field and say, this population needs me and they need to be seen, for you to even have the heart to, go shopping with them, to bring them stuff, and to understand there's much more to this person than just their brain injury, just their MS, or just their rheumatoid or Crohn's or whatever it is, that there's so much more to them. And oftentimes we feel passed on, like, okay, this is your new medication, be off with you. And they don't know there's so much more to us that we do, that we are. So thank you on behalf of all of us with chronic stuff, illnesses, that you took the time to care about us.
yeah. Well, thank you. I mean, I really wish that that was not the experience that most people had, and unfortunately, it's a story I've heard way too many times. Yeah, I'm thinking of, a situation. Maybe I won't go into that. I don't know if I should go into it or not. I'll pause here for a second in case you
Okay.
it. But there was a story when I was working at Bancroft Neuro Health, which is with that brain injury facility, um, where there was a direct care worker who, she just wasn't treating people well, right? Like she saw behaviors that she didn't like, and she treated people like they were less than a person, right?
Yeah.
And I never had that experience, but I also felt like, I just saw every person as a real person, right? You wanted to
Right.
be treated. If I was in that situation, I would want to be treated with respect and dignity.
Right.
And so without that, of course, you would get mad, or you would feel frustrated with somebody who's coming in and trying to take care of you, but not treating you with dignity. I mean, that
Right.
crazy.
Yes, for sure. I think most of us where we are now, once a month, I do for women. We have a lot of the women of MS, that just some amazing women who do a lot of advocating and just do some powerful, just work, that whether it's writing, whether it's just some awesome things that they do. And we call it Wind Down Wednesdays. And I would say that so many of us have had that experience, that we've been left or just not seeing us, whether it's some of us in a wheelchair, some of us just not seeing us for who we are. And so help me understand the difference, and why do we need a neuropsychologist versus a regular psychologist? So for those of my listeners who don't understand, they're noticing, like, they're having some anxiety, they're noticing changes in their body, in their life, maybe through COVID, maybe since that's when they're really noticing it more. Some things have really started to make them feel anxiety and depression. So they are going to pick up, and they can't find any names. The names they've been given by the neurologist are just regular psychologists.
Yeah.
So how do they find a neuro psychologist, and what's the difference?
Sure. So I think a general psychologist is really good at treating your basic anxiety and depression and bipolar and those kinds of things. But I think where neuropsychology or any of those other kind of health related psychology specialties come in is very helpful because one major point is we were taught from the very beginning, make sure that the health related stuff is ruled out before we blame this on an emotional disorder, right? So if somebody is having extreme fatigue and their doctor or somebody is saying that's just depression, well, we want to rule out the fact that MS is actually causing the fatigue before we say
Right.
in your head. So I think that's one of the main benefits to working with a neuropsychologist or health psychologist or rehab psychologist is that we're going to ask those questions about how much is the health condition impacting
Right.
mood symptoms, and how do we sort of pull apart the pieces so that we can get at how do we manage those health pieces, and then how do we manage the health or the emotional stuff that comes.
Right.
I would say that there's such an interaction between your health and your mood that it is sometimes hard to
For
pull
sure.
apart. But an example would be, when people with MS have word finding problems, right?
Right.
Can't get that word out.
Right.
I hear a lot of the people that I work with saying things like, I start to panic, or I stop
Yes.
talking in public, or
Right.
I don't do a podcast like this.
Yeah.
because I would never, I wouldn't want to put myself out there like that.
Sure.
I work with them to acknowledge the fact that that is a real frustration. And also, how do you manage that panic that starts to
Right.
rise in your chest when the word isn't coming out? So it's also sort of knowing that those medical symptoms have a real impact, and how do we get around that?
Exactly. And I love what you put in the questionnaire about even the cognitive and that it doesn't always have to be a medication. Sometimes it does, but there's so many other things, like whether it's, taking time to breathe, taking a look at how much sleep we're getting, taking a look at the medications. And one of the things that I loved when I read that, not loved, like this is a great thing, but I had to ask the neurologist, is there any correlation between, with my, degrees, is there any correlation possibly between the medications that I'm on and the cognitive issues I'm having?
Mhm.
And I'm like, why am I asking this? And so then, he goes back and he's like, we should move you off of some of this. And I'm like, okay, thank you. But the fact that we still have to come and ask that it's not, that they're not going through and saying, you know what, you've been saying you're struggling cognitively. I think that we need to take a look at your medication. That's not something they go to.
Mm-hmm. Yeah, and that's what a neuropsychologist would do. If you're just getting an assessment with a neuropsychologist, they would look at all of those factors. What other medical conditions, like sleep apnea is extremely common in MS,
Yes.
even if you don't have the typical sleep apnea risk factors.
Right.
And that can have a huge impact on cognition. So
For sure.
Get your sleep. We'd want to look at, are you on a bladder medication that's
Yes.
causing cognitive problems? And so, we're really ruling out all those other pieces before we say, this is only MS, because those things are modifiable, right? Your cognition can improve if you can improve some of those other factors.
So you put down, what would you say the percentages of us in, let's just say, the MS world that struggle cognitively?
So the average is about 65%. When people are diagnosed with MS, already about 30 to 33% of people are having some cognitive challenges.
Yes.
And it's a little bit different depending on whether you have progressive MS versus remitting, and also what kind of medications you're on. With some of the higher efficacy drugs, we're not seeing quite as severe cognitive problems as we're seeing in the past, but they're very new. So we're also seeing, how does this all play out in the long run?
Now, so I have a question for you, Megan. So this is completely personal, but I think it will relate to some of the other MS people that are watching. So for me, diagnosed so many years ago, when exercise and food and all of that wasn't even talked about. It
Yeah.
was, go home, eat whatever, that's not a thing. Rest, rest, rest. So like we talked about a little bit before, that just didn't make sense to me. I felt that movement was incredibly important, not only for what I understood, but for our moves, not only for that, but for atrophy not to set in. So what would you say about, my question is that cognitively, I noticed immediately I had some cognitive issues. I was trying to do homework with my kids, and all of a sudden addition was like, wait, where is that? I was trying to do easy multiplication, gone. I remember meeting my cousin halfway between her house and my house. So it was about 30-minute drive. Instead of driving home, I drove to her house. No idea why. And just thinking, what's wrong with me? What's going on? And not really, having people that knew me for a long time just saying, you're probably just tired, overstressed. I had, 3 little ones. And so it was more, thinking that, but in my mind thinking, no, there's something more. There's something happening that's bigger than this. So when we have those cognitive things in the beginning, I believe that what helped me in the beginning was things I didn't understand, but what I was doing, the exercise, the eating better. So I think that helped me, but I can look back now and say, thank God I did that, even though it wasn't something we talked about. So what would you say to that?
100%. And, I'm not an exercise researcher, but I was involved in a study where we looked at exercise. And so individuals with MS were able to choose whatever exercise they wanted to do. And we just tracked how their fitness, whether their fitness improved over 12 weeks. And if people's fitness improved, their cognition improved, specifically their executive functioning, meaning like their planning and organizing. So there's more and more and more data that's coming out that showing that exercise has a huge impact on cognition and on any kind of MS symptom as well. So, when you said that actually about that you were told to go home and rest, I do a lot of work with Can Do MS, and that's exactly, I think, what Jimmy Huga, who started Can Do, said, that he was like told to go home and rest. And as an Olympian, he was like, hell no, I'm not doing
It's exactly what I said. I'm going to run this out. So I would just go to the track and start running and say, screw this. I'm going to take this thing down.
And you were right. The data shows that exercise improves all factors of MS, including cognition. And so it's something that I recommend to everyone, and even just finding the right thing that every person can do.
Sure. And for me, writing, because of the cognitive stuff, I would go to write and realize I don't even know where a comma goes. I don't remember where periods go. So the grammar and stuff was just gone. So for me, what didn't leave was my endless amount of words that can come out. So that even I learned I did a lot of public speaking back then. So I learned to, I guess, in a sense, I would say for me, learning to find humor with it. So because I do a lot of teaching, learning to find something to laugh about with it, rather than it being so, letting the anxiety of losing the words and stuff like that get to me. So do you find that in your counseling that you help them find some kind of safety, humor, something that it's not all so black, it's not all so dark?
Yeah, exactly. I mean, I think every person has their own way of managing. And I find that a lot of people do use humor, and that helps them. Sometimes it's just sort of taking that pause and that deep breath and saying like, okay, I'm going to start this again. Or, that sometimes that's enough. But there's a concept in acceptance and commitment therapy, which is a style that I use a lot, where we have the frustrations of everyday life, and then we add suffering on top of it by beating ourselves up, or I can't believe I just did that, or and if the frustrations of daily life are enough, right? Like we don't need to beat ourselves up too. And so if we can take off that top layer, we're gonna be able to manage all of that so much more.
That's so huge what you said, Megan, because I hear that daily with my clients is it's the beating themselves up. I didn't have my bands together. I didn't have my stuff together. Please forgive me. And I think having it, I can say, slow down, breathe before we start, because I see the anxiety. So we're already not connecting mind with muscle. It's not connecting because you're in flight or fright. So I need you now to calm down. Let's breathe before we even start. So I love that what you said. I think that's absolutely 100%. So let's shift a little bit, go back to your to you. I want to know, so what brought you, how did you get to Johns Hopkins, and what brought you there?
Yeah, so that was a little bit interesting too. I was from grad school.
Mhm.
I did an internship at the Baltimore VA because that's sort of in the similar in psychology. We kind of do a residency like medical
Mhm.
school, but it's a 1 year internship, and then we do postdoctoral fellowship. And so I wanted to really specialize in MS, and so I did a 2 year MS fellowship funded by the MS Society out at
Mhm.
University of Washington. And I loved it out there, but my family and my husband's family were all on the East Coast. And so, really, the thing that brought me back is my grandfather got sick, and my dad
Okay.
called me and he said, you need to get back here, and I don't know if you'll make it. And I had this sort of like gut reaction of, I can't be this far away.
Right,
Um,
right.
I just started looking for a job, and we had some connections with Johns Hopkins, and I sort of reached out for a position that had nothing to do with MS, and I said, I'm looking just, if something comes up, or if you think that this position could be modified, I'd be really interested. Um, and it just so happens that another person on our faculty was moving, and they hadn't posted that position yet. And so there was an opening. So it was a little serendipitous, and that
Right.
the MS team didn't have a psychologist yet out at Johns Hopkins.
Shocking.
I know. I mean, we see 6,000 MS patients per year.
Right.
There's like no MS psychologist yet. So they were excited to bring somebody on who had MS experience. And so it all just sort of worked out in kind of a weird way, It's
Yeah, I love because you really do. So many times I will ask a doctor now, tell me about your MS, experience, what you know. And I'm shocked by the time they'll say, oh, I do know a lot about MS. And I get there and I'm like, I'm telling you about MS now. You actually don't. So just be honest. If you don't know about it, just say that and then let me decide, is this a doctor that has to know or not? So I
yeah.
love that you actually do know. So thank you. So yeah, so then you got there to Johns Hopkins, and then what?
Yeah, so I got there, and I really was interested in research,
Mm,
and so I was working on a research study where we are looking at how can we increase access to cognitive assessments, because as you
mm,
mentioned, it's really hard to find a neuropsychologist, especially if you're in rural areas.
right.
And they're very expensive, they're time consuming, it's very hard to get into an in-person office. So we were looking at an online program that was developed by Harvard.
Mm,
You can find it online. It's called the Many Brains Project.
mm,
And so we were looking at that in MS and validating it for the MS population. Um, I was also doing clinical work, so I primarily see people for psychotherapy and cognitive assessments.
okay.
After a couple of years, I got involved in, we have a precision medicine project, which means that we're looking at how can we tailor our medical treatments, our rehab treatments to the right person at the right time, for the right reasons, right?
I
Because
love
everyone's
that.
different. Yeah. And
Yes.
yeah, go ahead.
No,
Well,
you developed even
yeah.
an app and you developed like all this stuff. So brag on that.
Oh, well, so I mean, I think one thing that I saw when I was at University of Washington was that
Mm,
the cognitive screeners that we recommend, that the MS Society basically recommends that everybody
right.
get every year. Um,
I've never had one.
yeah,
It
that,
was just introduced to me that I needed to have one. I was like, a what?
yeah,
So
yeah, yeah. And that's what I was hearing, is that people weren't getting them,
right.
and they were annoying to administer, which is probably the reason that people aren't getting them.
Yeah.
And so we developed an app to try and make that easier and more efficient.
Mhm.
And uh, that actually didn't pan out, unfortunately, because
Okay.
the testing companies and copyright, all that kind of stuff. But I think that there is one that is that sort of followed after us that was created by Biogen that is widely
Okay.
available and free. Um,
Mm.
and so now all the people in our center are getting cognitive evals every time they come in. It's a
Okay.
90-second test. But I'm
Yes.
hoping that continues to sort of go out into general neurology and more MS centers across the country.
For sure. I echo that. We need that because there is so much that we're like, am I losing this or does it just feel like I'm having a bad MS week? And so I think that's so important that we have more testing. And I'm looking forward to it, but not so much because it is difficult to know, oh my gosh, I've lost this much. But we need that baseline to go by. And without that is incredibly frustrating. So, and I think to your point, I think it causes a lot of the depression, the anxiety, even more so because we don't really know what we've lost. It
Right.
feels like, I think a lot of times it can feel that we've lost more than we've actually lost if we're
Yes.
not getting that.
Yeah. Yeah.
So,
Well, and I also think you can do something about it earlier, right? So sometimes it gets dismissed, and
right,
as maybe people were saying to you, well, you're just overtired. Well, now you
right,
have an objective marker that says,
right.
here's something that we need to do something about. Whether
Yes,
a shift in medications, whether that's seeing a cognitive rehabilitation specialist, like PT for your brain, you know,
right,
you want to do something about it earlier,
right.
progresses. So,
100%. So now how long have you been with Johns Hopkins now? How many years?
I'm going on 6, moving into 7, I think, this year.
Okay. So
Yeah.
what's been the most exciting since you've been there that you've been able to develop and say, this is my favorite thing that we've got thus far?
I would say it's just the people that I work with in my lab. So Abby Hughes, Dr. Jackie Batrai. Our emphasis, whether it's in, Abby specializes in sleep. Jackie
Hmm.
specializes in health disparities. I'm really interested
Right,
in kind of mood and cognition. But
right.
our emphasis as a group is increasing access to care. And so
Yeah,
we all come at it at different angles, but I just think that that's such a huge need and something I'm really
yes.
excited about.
Yeah, I love that. Now, how would you say moving forward? I know we talked a little bit beforehand that telemedicine has been so big in psychology.
Yeah.
So, do you see that continuing to move forward? Do you see that that we will still be able to have that, or do you see them stopping that?
I think, I'll say this. There was a dean from Johns Hopkins who we
Mhm.
had a small group meeting with, and this question was being asked last year. And he said, you can't put the genie back in the bottle, basically. Like, people now know that this is
Right.
an effective way to get their treatment, and
Yes.
it's a way that they can access it without all the burdens of
Right.
find childcare and all that stuff. I just don't see this going away.
Right.
You know, there's going to be some bumps and challenges with insurance coverage and all of that stuff.
Sure.
There's too many people advocating for it on many
Mhm.
fronts for it to go away.
Yeah. And I think too, you've got more patients than ever,
Yeah.
voices coming out, where
Yeah.
before we were kind of shut down. And I would say many of us who've had the diseases for many moons, like I have, it wasn't something we did. There weren't influencers. We didn't go on and talk on social media
Yeah.
about our disease. We hid it. We didn't want anyone to know about it. So now we've got all of this ability to advocate and for patients to say, no, no more. This isn't okay. So I think that helps a lot with not just psychologists like you and doctors like you that are pushing for that, but also our patient voices saying, nope, like you said, the genie's out of the bottle and you're not going to be able to get that back in.
Yeah.
So we know that we can do this now. And it's like, this is easier for so many that find it. So like you said, for them to go to a doctor's appointment for those who have, are severely handicapped is so, the idea of it is so daunting and so difficult that talk about getting depressed, just going to the doctor and the anxiety for that. And then being able to breathe, knowing all they have to do is put it on their phone and be able to talk with you. What a huge relief knowing that, rather than I have to get into the car, I have to get my wheelchair, I have to get this out. So yeah, I think you're right. I think that now that has been open, I don't see that being able to go away.
Yeah. And the research really stood even prior to COVID. One of my colleagues, one of my mentors, really, Dawn Eady from University of Washington, she has been doing decades of research on distance-based interventions for psychotherapy. I mean, phone-based psychotherapy,
Right.
Zoom-based psychotherapy, individual, group. I mean,
Right.
we in Washington, we were caring for people in Alaska, in Idaho, in Montana, and people can't be flying in from Alaska for a psychotherapy
Right.
appointment.
Right.
It's not acceptable. So, and her data all showed that there was no difference between whether somebody was on the phone doing psychotherapy,
Right.
even without the visual cues,
Right.
being in person, right? So
Right.
even for people who have difficulty with technology, I mean, that's one of the arguments against it. We know that phone-based therapy
Right.
doesn't work. So
I was going to say that there were times when when I would be on the phone with my counselor, and I would actually what was very helpful is I would be outside. So I needed that. So I excuse me, I've got a frog in my throat, so hold on. Okay, sorry. I thought that it allowed me to actually process more because I was able to sit outside and enjoy that. And so I appreciated the fact that I could just be on the phone and, not. And then I thought, gosh, for someone which I experience a lot with my clients, technically they're struggling with getting on Zoom. So for that, it is so much easier just to do a phone time with them. And I think you're right. I never felt that I was slighted from that. So I love that.
Right.
So
it's protective for people.
Yeah,
feel a
for
little
sure.
nervous. The phone is a good way to still be connected, but maybe
right. So explain what we talked about before. So if I want to see you and I'm in Michigan, so people are listening and they're in different states, and I'm like, I'm reading this and I'm like, okay, Megan, I need to make an appointment with you. I need to see you. Cognitively, I am a mess. I need to see someone who understands what I'm going through. I've been given names of different psychologists. I've tried to talk to them. I get this far, but then they understand what anxiety is. They understand what some of the things I'm talking about, but they don't get what it means to have it with a chronic illness. Yeah. So how do I see you? And what is a way that they make that possible?
Yeah. So, right now there's a lot of legislation. Again, this was happening pre-COVID, but it's definitely escalated and made it faster. There's something called PsyPact, and if you Google,
and this will be on don't stop your car, it'll be at the bottom of the show notes. So
yeah. So if you Google PsyPact, or if you look on the show notes, there are now, I think, 27 different states that have enacted legislation which allows you to see a psychologist who has PsyPact approval, basically, which is very easy to get. You can see them from whatever state you're from. So right now I'm seeing people who live in Maine. I see people who live in Georgia. I see people who live in many different states. And
we're working on Michigan has started, but we're still right.
They've enacted, or the legislation was approved, but not enacted, I think. Yeah.
So if it's easy to do, why do you think so many states are pulling their feet and not getting this done if it's an easy thing to get done?
Yeah. So, well, the approval for psychologists is not easy.
Okay.
I think the legislation, I mean, I guess it probably just depends on the state, right? One of the challenges is that every year you renew your license, right? And you pay the state that you're licensed in your renewal fees. Well, if you can now see people in 50 different states, or in different states, I think that there is some fear that maybe less people will get licensed, and maybe licensing
Right.
will be diminished, or um, there's lots of probably political reasons that I don't even understand. But
Sure.
I think now, there's been a huge shortage of mental health providers, and there was a lot of incentivizing people to move to different rural states
Mhm.
that have as many mental health providers. But I think with PsyPact, and I think that social work is actually doing something similar. Um, this is going to really open the world for people who don't have a psychologist in their town. And maybe, like you were saying, you could find a really specialized mental health provider
Right.
who maybe isn't
Right.
nearby. Mhm.
Yeah, absolutely. That's one of the biggest things that I hear for myself, even when, like we talked about a little bit before, finding out that during COVID, having, to redo my life and my job, and find out I was JC positive, and just the world kind of coming down. And, always feeling very comfortable with psychology. It was something I really wanted to go into. And so finding it like a checkpoint, thinking, okay, I need to check in. But then that frustration where I'm explaining more about multiple sclerosis than they actually know. And so there's that frustration that I feel constantly it happens. So it's very difficult for us to find you to find the neuropsychologist and the neurologist and stuff like that. It's not brought to our attention. The neurologist doesn't introduce that to us. So in a lot of places, unless you're in a big group, like when I visited the Cleveland Clinic, you've got all of the people kind of there.
Yeah.
So I find for me here in Michigan, I've got to kind of put my people together on my own. It's not something readily available to me.
Yes.
So
Yeah.
for
Well,
those people, what do you suggest to put on, because when you're first diagnosed, they say, put your people together, get and it's like, if you live in an area that you don't understand what that means, make sure you have your doctors and all your stuff in order. It's like,
yeah.
who are those people?
So a couple of things. I mean, I think the navigators at the MS Society are good. I've heard mixed reviews. Sometimes people get a lot of benefit. Sometimes people
Mhm.
maybe are still looking. I think if you Google those things like health psychology, rehab psychology, and I can provide you links for the show notes too.
Perfect.
There are different divisions within the American Psychological Association where you can find those psychologists that specify their interest in those areas or their experience. Um, but the thing that you mentioned is something I've heard so often that I did kind of start this side business, find empathy, because I hear not only from people with MS, but outside of it,
Right.
they're looking for mental health providers who know
Yes.
their condition, and that they don't have to teach them about it. And so one of
Yes.
my goals is to try and give continuing education credits to mental health providers to help them learn about different medical conditions. So if somebody walks into their office with a rare medical condition, they can like pop this,
I
podcast
love that.
and
So
listen.
explain to me about what Find Empathy is. So I've listened to a couple of them already, and I'm like, I love this. So explain what it is, how it got started, the podcast, and how doctors can come in for to get further education from you. How does that even work? And how did you even think up, this is what I'm going to do? I'm going to start a podcast now. I've got so much extra time. I'm going to do a podcast.
Yeah, I mean, I think it was from hearing people like you who said,
Mhm.
I've had multiple experiences. I've been through 3 community psychologists, and then I found
Right.
out that you existed, and
Right.
oh, I'm going to go to the psychologist that really knows MS. Or seeing the relief on people's faces when they don't have to describe to me why, um, the JC virus is scary, right?
Right.
And I mean, I've done some speaking for, like I said, Can Do MS, and I remember there was one woman who came up to me afterwards, and she was like, "Where do I find somebody like you that lives near me?" Right?
Right.
So it just even physicians. I was in a
Yes.
meeting and physicians were saying, well, we stopped screening for this in our clinic because we don't have anybody to send our patients to. I was even on a board meeting recently where somebody said, well, is there education that we can, that psychologists get that so that they know what MS is? And so all of these kind of like just I kept hearing this again and again and again.
Yes.
And I said, this is a huge need that needs to be filled. And um, so I first started like I'm just going to create a directory where we
Mhm.
just list psychologists who have this experience or social
Right.
workers or master's level therapists. And I went to the MS Society and others and said, hey, do you have recommended providers that you really like? And they said, well, we do,
Mhm.
but we don't have that many. So I think that directory was not enough.
Right.
We need to create more people who know these things. So
For
that's where
sure.
podcast continuing education piece came in.
Yes.
Podcast more because I think it's easy, right? And my friends who are in private practice said, we don't have time to sit down and watch a 5-hour webinar on MS.
Right.
And
Right.
it takes away from my time with my kids and all this kind of stuff. And so I thought about the podcast idea and I made one of the first ones just as a demo and I gave it to one of my friends and she was like, Megan, this is amazing. I walked
Yes.
the dog. I took my kid to school and I was listening
Yeah.
to it and I could get my continuing education credits without
Yeah.
having to sit down and, give up 5 hours of my day to do
It
this.
is, it is an awesome idea, and I've enjoyed listening to it. And I love that your husband was the first person to interview you. I love that because my husband is like, oh my gosh, I know I have to do this with you. So, how was that? Was that awkward or was it fun?
Yeah, I think it was fun. I mean, he's been very, very supportive, which is
Yeah,
great.
for sure.
He's
Sounds like it because he moved with you, moved back, but you guys have done that for each other. So,
Oh yeah, yeah. I mean, he's been very supportive. He's followed me all over the country,
yeah.
He's just
Yeah.
yeah, he's
So
he's
how
really
many episodes do you have now of the podcast? Where are you at now?
so this is still like very brand new. I have three
Mhm.
released, three official episodes
Mhm.
released. I have 11 kind of either recorded or half recorded because I'm trying to have different voices in each episode so
Sure.
that actually lives with it and also
Sure.
research because I think both are very important. And then I'm talking to some different experts or people that specialize in other areas like long COVID, people who have symptoms after
Right.
having COVID, or a couple of colleagues who both research breast cancer but also have had
Mhm.
breast cancer. So we're talking about doing something in that or women's health. And
I love that.
yeah,
Women's health. So that would be something, gosh, I'm probably going to hit you up again to do when we do our wind down Wednesday, because it's all women
yeah,
and talking about women's health issues. We did talk about, we had a off topic of this, but sexuality and intimacy
mhm,
and something that is not discussed. So I did it with a men's group and then a women's group,
mhm,
and something that is just not discussed enough about the fear of that and the
yes,
fear with women and what we lose and the misunderstanding and just the hush, something, a no-go topic.
mhm,
And it was really great to have these really well-known women discuss, what they do and the concerns and the numbness and all the things that we struggle with. So I
yeah.
think that's, you have such a warm and compassionate way to just hearing you. I'm like, I need to see you. So I think, having that women's issues and talking about that, I think is so big because there's so many emotions that we carry with that. And so where do you see yourself, your biggest topics in that?
Yeah, I mean, well, I mean, even within MS, but also outside of MS, it's super common. I think before I had kids, had a kid, nobody talked about bladder issues or things like.
Right.
I have a couple of friends who have seen pelvic floor therapists for.
Yes.
I myself had an AVM
Mhm.
uterine AVM that burst, which was super scary. And
Sure.
and I couldn't find a physician that, well, I
Right.
went through several physicians before they figured out, had one that even had seen it before, right? So,
Right. So I was going to say that's probably extremely rare.
right, yeah. And, I think that this is so many women experience all different kinds of sexuality and health issues that
Yes.
need to be talked about more. Within MS, I mean, I had somebody who told me the other day that they had talked to their physician several times, and their physician said, "Oh, nothing can be done about that." And there's lots of stuff that can be
Yes.
done about it. So, if it's not talked about or brought out into the open, then we won't know, how
Yeah.
to go and how to fix it.
I might have you back again talking about that specifically because it's something that we don't understand. And most women, if they are brave enough to discuss it,
Mhm.
we got a lot of feedback from that one, and just help me understand who do I go to talk about this stuff, who can help me with that. So that was both men and women. The men were feeling very down, very depressed because they could no longer please their wives anymore. They could no longer experience any pleasure. So it was just a very eye-opening, and I was grateful that people were so honest and open and willing to discuss that.
Yeah.
So I love that you're going into some more women's issues. And as you know, when you've got one autoimmune disease, typically you've got some more things going on. So like I've got rheumatoid with it, and we've got a lot of MS patients that do struggle with cancer as well. And so there's so many issues that are all mixed in together. So I love that. So with the podcast that you've got, where do you see that? If you look a year from now, where's your hope that goes?
Yeah, I mean, my hope is that we'll be able to keep expanding. I'm kind of the one person working on it right now, which and I'm still trying to work part-time at Johns Hopkins and do this as well. So it's slow going, but I have a lot of confidence that it will continue to grow over time.
Mhm.
My hope is that maybe I could bring in other people who are experts on different topics and have them sort of run a series on their expertise, and so
Yeah.
grow a little bit faster that way. So it's really just sort of I'm navigating these new waters of the business,
Right. I
and
love that. You are extremely driven. I'll tell you that. I'm reading your stuff and I'm just like, wow, this woman is driven. And I know from the bottom of my heart and many of my listeners, we can only say thank you. Thank you for all that you do for all of us in the chronic illness world, and for your heart. And I'm so grateful that I finally made the choice to get on Twitter, because it's one thing that I was like, I don't want to go back on Twitter. And so going back on, I was able to find so many, and to find you was just so exciting. I immediately messaged you, and I just was so excited to find you. And just what a wealth of knowledge and what a huge heart you have. So I want to definitely have on the show notes where they can get a hold of you. And so they can email you, and they can obviously try to, so if somebody wanted to get a hold of you, we'll have that. But you've got on Twitter, what's your handle on Twitter?
it's Meghan Beier, Beier PhD. I'm also on LinkedIn. I have a Find Empathy page. If you Google Find Empathy page on Facebook, and you can go to the website findempathy.com, or you can email me at megan@findempathy.com.
Yes. So, and again, that'll be at the bottom of the show notes. But gosh, I could talk to you forever. This could be a 3-part, but I look forward to discussing more things with you at a different time. Thank you so much for being on. This was so good for so many of us. And I think that it'll be so eye-opening for a lot of us. And so thank you so much. It was a pleasure to have you on.
Thank you so much for the invite. It was a lot of fun.
Absolutely. We'll talk to you soon, and enjoy the rest of your day, guys. And as we always say, move the body, move it, don't lose it. And we came to disrupt any of the ideas that you can't do things. There's always a way that we can do it. So for today, have a great rest of your day, guys.
Well, thank you so much for joining us today on Move It or Lose It podcast, where you can again find us every Tuesday, and also wherever you like your podcast, whether it's Apple, Spotify, Stitcher. Join us on that, and we can't wait to see you again. We're going to have a lot of exciting guests and working together. And as always, you'll hear us say at the end of every podcast, we are stronger together. So let's do it. Let's become stronger together.